Thank you for an impressive introductions and good afternoon, everybody. So, thanks for the organizing committee who is giving impressive chance or opportunities to share and discuss with you guys about how to make use of the multi-omic study, in particularly to study about the heterogeneity of the cancer patients. And I'm actually coming from the faculty of associated medical science. So I would like to emphasize you also about how to use or the applications of the multi-omic study that you can apply into the clinics or the clinicians. I mean, you can work with the clinicians by using these basic knowledge or integrative multi-omic analysis. So there are about 3 to 4 words or terminologies that I would like to emphasize for you again after my talk. First one is cholangiocarcinoma, of course. Second one is about multi-omic study. And also how to use the multi-omic study to review or opens, describe the tumor or tissue heterogeneity. I will discuss a little bit about the targeted therapy that we can, make use of the data from the multi-omic study and apply to understand the targeted therapy, particularly for cholangiocarcinoma patients. And I will touch a little bit on my pilot study about the liquid biopsy in cholangiocarcinoma. So I hope that you will have fun and enjoy my talk. So let me give you a brief introduction of cholangiocarcinoma. I believe that at least 90% of us staying here knows about this type of cancer. Cholangiocarcinoma, or CCA shortly, is a cancer that arises along the biliary tree. Currently, the classifications of cholangiocarcinoma is mainly based on anatomical locations, intrahepatic or extrahepatic cholangiocarcinoma. Even though it is a rare cancer, however, it can be accounting about 10 to 15% of all hepatic cancer. As I mentioned earlier, the incidence rate of cholangiocarcinoma or CCA is rare worldwide. However, in the past decade, we also observed the increasing rate of this type of patients. Unfortunately, the highest incidence of CCA is actually occur or happens in our areas, of course, in Southeast Asians, particularly for Thailand, Vietnam, Cambodia, and not only Southeast Asia, increasing rates were also observed in China and Korea. I would like to emphasize that there was, so many reports reported about the association between cholangiocarcinoma and liver fluke infections. So that's the underlying mechanisms that why the incidence rate was reported in the area that has the evidence or endemic area of the liver fluke, particularly for the northeast part of the Thailand. Nowadays, there are many risk factors has been well described that drive cholangiocarcinogenesis. One of the main factors is about liver fluke infections, which includes Opisthochis viverni, Opisthochis filius, and also Clonochis sinensis were reported mainly in China. And some of the other factors, including the primary sclerosing cholangitis, hepatitis infections, and other benign biliary conditions are reported to be involved in CCA in Western country mainly. And of course, one of the main factors is about the genetics and epigenetics variations, which I would like to discuss with you again, today. There are so many attempts or trying to deal or cope with the problem of cholangiocarcinoma worldwide. However, nowadays, there are so many challenges or problems or limitations observed in cholangiocarcinoma patients. Firstly, most of the patients come to the clinic when they have the advanced stage already. That resulting in the poor prognosis. So there is about 5 to 15% of the CCA patients come with 5-year survival rate. And also, CCA can be considered as one of the most heterogeneous cancers in terms of topographical, morphological, biological, and clinical point of view. One of the main challenging is that for the diagnosis and prognosis of cholangiocarcinoma, nowadays still lacking of the specificity and sensitivity of the biomarker, either tissue biomarker or blood-based biomarker. So there is an urgent need to develop the biomarker with high specificity and high sensitivity in this type of patients. So the research and the talk that I would like to emphasize again is actually done by us and our international collaborations we working with the National Cancer Center of Singapore, Duke and US, GIS, and of course the Cholangiocarcinoma Research Institute, Khon University. We actually trying to do the genomics and epigenomics profilings in cholangiocarcinoma patients. Our international collaboration is actually started before 2012. But then the collaboration has been, growing. So today my talk would like to show you and discuss with you guys about the usings of the multi-omics analysis, which is actually the study under the ICGC projects with the international collaborations. So I would like to talk mainly based on the ICGC study, and I will touch a little bit on how we move on from tumor tissue to liquid biopsy. So in the ICGC study of cholangiocarcinoma, so this data is contained about almost 500 cholangiocarcinoma patients. We included the CCA tumors from about 10 countries. Of course, various etiologies. We divided the samples into 2 groups based on the endemic area of the Liverpool. Also, the Thai CCA sample is actually included in this type of the subgroups of 130 Ts. And another group is the non-fluke related cholangiocarcinoma, which actually mainly based on the Western cholangiocarcinoma patients. So what we have done, we did the whole genome sequencing for the tumor tissues of the CCA patients, and then we study the mutations that occur in coding regions. Of course, we find the somatic mutations, and also we also look for the structural variation mutations. We also reported by informatics pipeline to report or capture the mutations occur in non-coding regions. And not only the WGS, we did profiling the other genetics and epigenetics variations in these groups of the CCA tissues. We include the 200 whole exome data from Japan. We did the deep targeted sequencing to specifically identify the somatic mutations that we interested in at that time. And we did the SNP array analysis, of course, gene expression array, and lastly, the whole genome methylation array also done in this study. So I would like to share with you guys about the results that we got from this study, mainly the genetic heterogeneity for somatic mutation, structural variations, and I will touch a little bit on the epigenetics alterations that we observe. We do find the distinct epigenetic patterns in one cancer type. So let's start with the genetic heterogeneity that we observed in these 500 cholangiocarcinoma tissues. So we got the publications for this result in Cancer Discovery. This one is unsupervised clusterings that we do include the whole genome sequencing data, SNP array data to identify the copy number variations, gene expression array, and also the genome-wide methylations array. We do unsupervised clustering without the clinical information put in. We just put in the molecular profiling. So we were able to reclassify the CCA patients into 4 distinct clusters. I would like to emphasize the 2 main clusters that we observed. You can see that CCA cluster 1 is actually harbor the CCA tumor that accumulate with the high mutation patients, high somatic mutation patients. And this cluster, CCA cluster, is actually comprised mainly fluke-related cholangiocarcinoma. In contrast to CCA cluster 4, you can see mainly CCA tumor that cluster in this cluster is actually mainly non-fluke-related cholangiocarcinoma. You can observe that there is actually exhibited low frequency of somatic mutation. These genes expression patterns also observed. I would like to also emphasize here that in this one cancer type, cholangiocarcinoma, you observe at least 2 hypermethylation patterns in different regions. If you zoom in into the somatic mutation, you see that this CCA cluster 1, is actually accumulated with the defect or alterations of the pathway that involved in the DNA repairing genes. However, in CCA cluster 4, you can see that there were an accumulations. There is an accumulations of the genes so-called BAP1, IDH1, and 2, which I will emphasize about these gene later. But now you can see that we observe the tumor heterogeneity based on these intricate multi-omic study without the clinical information that we put in. So next, if we focus on the somatic mutated genes that we observe in cholangiocarcinoma, of course, there were some of the genes that were mutated in common between fluke negative and fluke positive. However, I would like to emphasize that there are some of the genes that were distinct or mutated in just one group. For example, in fluke positive, you can see that there was a high frequency of significantly mutated of KRAS gene, FBXW7, RASOL1, and SF3B1s. However, in contrast to fluke-negative cholangiocarcinoma, you can see that there was an accumulation of the somatic mutations of the other genes. If you are the clinicians or the scientists that work in the clinic lab that provide the genetic testing lab, you might have familiar with some of the genes that already includes in your genetic testing panel. We then try to compare whether does the somatic mutation that we observe in these 2 CCA patients are actually different or similar. We reported that there are some of the genes, for example, KRAS were actually, KRAS and SMAD4, FBXW7, TP53, and MSH actually were, defects in just only one subtype. And also, we reported the novel significantly mutated genes, for example, STK11, RASOL1, and MAP2K4. STK11, at the time we observed, it's kind of actually the novel mutated genes in cancer. Nowadays, some of you guys may have heard that STK11 is already included in the targeted sequencing panel for lung cancer. So at the time, we did try to, go deep to the molecular mechanism, how STK11 drive the cholangiocarcinogenesis. I would like to also emphasize here again that amongst those significantly mutated genes, we try to group whether where does the pathway that they come from. So at least 50% of the CCA tumors has at least one defect in the genes in kinase RAS pathway. I would like to emphasize is that from our whole genome sequencing data, you see here, the arrow here is the arrow that points to the CCA tumor or the patients that had FGFR genes alterations. FGFR genes alterations. So you can see that there is an accumulation of the CCA tumors who has FGFR genes alterations, mainly in fluke-negative cholangiocarcinoma. So we do see these interesting patterns. Then we try to what happened, why there are so many differences in terms of the frequencies of the CCA tumor that harbor FGFR gene fusions. Next, we then expand our study cohort, which actually done by Dr. Srinya Kongpet, just published in 2020. We captured that question. So we expand our cohort. We did the targeted RNA sequencing, particularly to look for the FGFR gene fusions in CCA tumor. What we include about 200 CCA tumor and did the targeted RNA sequencing that capture FGFR and its fusion partner. Firstly, I would like to emphasize the frequencies of the CCA tumor that harbor the FGFR alteration. Almost 20% of the CCA cases in fluke-negative cholangiocarcinoma harbor at least one FGFR fusions. 13.6% of the CCA, fluke-negative CCA tumor harbor FGFR2 fusions. FGFR2 fusions. You can compare the frequency, lot less frequency was observed in fluke-negative cholangiocarcinoma. Remember, this is one cancer type. All the patients are actually CCA, but with different etiologies. Fluke-positive cholangiocarcinoma harbor less than 1% of the cases with FGFR fusions. Next, we investigate whether these fusions is actually the main driver. We do see that the cases with FGFR2 fusion is actually mutually exclusive. I mean, there's no others fusions in FGFR. There's no other alterations observed in the same patients. So that means mutually exclusive. So as we hypothesize as FGFR2 gene fusion to be one of the main driver or main underlying mechanism that drive cholangiocarcinogenesis. So next, from whole genome sequencing data, we try to find whether is there any specific partner of the FGFR2 genes, right? And the results coming up that from this class plot, you can see this is the locations of FGFR2. It actually can be fused with so many genes. I mean, various types of the genes come from the different chromosomes. So currently, from CCA tumors, there's no specific partner for FGFR fusions. So in whole genome sequencing data, we also report the underlying mechanisms of why FGFR2, the expression of FGFR2 is actually increased in CCA tumor. You can see is that if we found FGFR2 gene fusions, FGFR3 gene fusion, it doesn't matter whether what are the fusion partner. However, the domain, conserved domains of its partner is actually can activate the kinase domain of FGFR. So we suggest that this may be the underlying mechanisms that drive FGFR, works increasingly and drive the cholangiocarcinogenesis. One of the new mechanisms that we observed in our CCA tumor is that one of the cases that is actually loss of the 3' UTR of FGFR2. So these losings of the 3' UTR we proved in vitro study that actually resulting in the increasing expressions of the FGFR2 also. So, in terms of tumor heterogeneity, I would like to emphasize what we observe is that we observe the alterations of FGFR genes family, mainly FGFR gene fusions that were actually significantly enriched in non-fluke associated CCA when compared to the fluke associated cholangiocarcinoma. And not only that, FGFR2 gene fusion positive CCA tumor were exclusively, happily, mainly in intrahepatic cholangiocarcinoma and were mutually exclusive with other somatic mutations. What is that information? Why is that information is important? Because currently there is an inhibitor or FDA-approved drug for FGFR2 gene fusions in other cancer, but it is specifically for FGFR2 gene fusions. So in this case, this data is suggesting that it's not worth testing these drugs in Thai CCA, right? Because you see only less than 1% of the cases that have FGFR2 genes fusions. Okay, not only FGFR2 fusions that we observe the heterogeneity or distinct patterns between the CCA tumor with different etiologies. We do see this one. The pattern of some of the copy number variations were also distinct or difference between CCA with different etiologies. I would like to emphasize here the copy numbers, particularly for ERBB2 or HER2 genes amplifications, which actually enrich in fluke positive cholangiocarcinoma. And this amplification is actually resulting in the increasing expression of HER2 genes. Why is this important? Because there is an HER2 inhibitors either on clinical trials, and one of the drugs is actually already FDA approved. So I think for HER2 inhibitors, it might be worth for testing in CCA tumors in our area. So for the tissue heterogeneity, I would like to summarize or include in this table. You see that distinct genetics patterns that can be targeted. It is obvious that in CCA cluster 1, you see the defects of the DNA repairing genes. You see the increasing or alterations of HER2 amplification that resulting in the increasing expression of HER2, suggesting that this CCA cluster might be worth for testing for HER2 inhibitors. I didn't mention earlier, CCA cluster 1, we observed that CCA cluster 3, shows the increasing expressions of the genes that related to the immune checkpoint. So there is an opportunity to test for the immune checkpoint inhibitors in this CCA cluster. I would like to say that CCA cluster 4 is kind of lucky cluster, because you can see there are so many alterations that can be targeted. For example, enrich in FGFR alterations and enrich in IDH1 mutation, which currently there are so many drugs on clinical trials, and at least 2 of the drugs, IDH inhibitors and FGFR inhibitor, has been already approved by FDA. So this is the update of the, to emphasize that there is an tumor heterogeneity when compared either in CCA, when compared between intrahepatic cholangiocarcinoma and extrahepatic cholangiocarcinoma. You see that there is a distinct frequencies of the somatic mutations in terms of anatomical subtype. Up to date, the FGFR2 and IDH1 are the best understood target for treatment on cholangiocarcinoma. Okay. Previously, I talked about the genomics heterogeneity. So let's look at the epigenomics heterogeneity that we observed in our study. I would like to emphasize that we use the genome-wide methylation array to understand the underlying mechanism that drive the CCA tumors with different etiologies. What we see, we expand our study cohort again. We try to do, we perform the whole, the genome-wide methylation array in 138 CCA tumor, and we were able, to classify the CCA patient with the the distinct hypermethylation pattern. Interestingly, in CCA cluster 1, we observe the hypermethylations mainly in CPG's islands. In contrast to CCA cluster 4, we observe the hypermethylation mainly in CPG chores. Remember, this is only one cancer type, Iceland and chore, and we do see the pattern, the genes. We do see the different gene sets that were hypermethylated when compared between CCA cluster 1 and CCA cluster 4. So we next try, we think what is the underlying mechanism that drive the epigenetic heterogeneity? So we look at the gene expression data first, and we do see is that in CCA cluster 1, we do see the decreasing or down expressions of the genes TET1, and also we do see the significantly increasing of the gene expression of ECH2 in CCA cluster 1. However, in CCA cluster 4, we look at the mutations that occur in this CCA cluster, and we do see that the hypermethylated CCA sample in this cluster harbor mainly BAP1 mutations. We already exclude the tumor with IDH1 mutation because we already know that IDH1 mutation is the main driver of the hypermethylated phenotype in various cancers. So we hypothesized that in CCA cluster 1, there was a down expressions of the DNA demethylase enzymes or TET1, increasing expressions of histone modifier. However, in CCA cluster 4, we do see the genetic alterations that may later on drive the hypermethylation patterns, particularly mutations in IDH1 and mutations in BAP1. So this is the hypothesis that we propose in this paper. We are trying to do the, functional study for particular genes to prove our hypothesis. Not only those underlying mechanisms that we propose, we do see that there was an elevated of C to T mutations that might link to the DNA hypermethylation pattern. As you can see is that in CCA cluster 1, there was an C to T mutations that were located near the hypermethylated regions. So before I would like to propose the mechanisms, I would like to conclude here again that from genome-wide methylation array in CCA cluster 1, which mostly comprise of the fluke infections and the CCA tumor with higher mutation rates and accumulation of signature 1 mutations, which might increase the subclonalities in CCA cluster, in this cluster. However, in CCA cluster 4, which is mostly non-fluke cholangiocarcinoma patient, is more clonal because it's actually mostly accumulated with the IDH1 and BAP1 mutations. This fluke infection might induce the epigenetic deregulations and later on susceptibility for deaminations and mutations at the methylated sites. So we propose that this event might lead to cancer heterogeneity when compared CCA cluster 1 and CCA cluster 4. To sum up, we propose the underlying mechanism that drive the different carcinogenesis pathway in CCA cluster in this slide. In CCA cluster 1, which comprise mostly the fluke cholangiocarcinoma, fluke-associated cholangiocarcinoma, and it has elevated or increased mutation rate, accumulation of signature 1. And these procedure or processes is actually come from the carcinogens. This one is the liver fluke. Carcinogen-induced methylation, deamination, and mutation, which is inherently stochastic from cells to cells. So we propose that these events might actually increase the intratumor heterogeneities. When compared to CCA cluster 4, which is comprised of mostly the non-fluke cholangiocarcinoma, and we observed that there was an accumulation of the mutations, mainly in chromatin modifier genes, for example, IDH1, IDH2, and BAP1, which this event may occur primarily even preceding epigenetic deregulation. So you can see is that we propose a distinct pathway that drive the tumor development in one cancer type. Previously, I talked about mainly on tumor results. So I would like to touch a little bit on how we move on from tumor tissues to liquid biopsy. You guys may have heard, because in the past decade, the term of liquid biopsy has gained more interest. So this is the part I would like to next talking about. As I mentioned, that one of the challenges of cholangiocarcinoma currently in routines in the clinics from blood-based biomarker, there are two main markers, CA19-9 and CEA, that are used to be the main blood biomarker for diagnosis and prognosis of the CCA patients. But the problem is that those markers lack of the specificity and sensitivities. How about tumor-based biomarker? We all know that sometimes the tumor tissue is difficult to be obtained, particularly for the patients who actually didn't go for the surgery, right? So that's why there is a needed to find the molecular marker in liquid biopsy. So let me introduce a little bit what is liquid biopsy. So liquid biopsy is a term or the alternative method that make use of the body fluids, for example, blood, urine, CSF. In this liquid biopsy, comprise or contain micro or macromolecules. So the main molecules in liquid biopsy is actually include the cell-free DNA. So cell-free DNA or cfDNA shortly is a small fragment of the nucleic acid or DNA that's released from cells. It can be released from normal cells in normal conditions. Of course, in tumor cells can also release the circulating tumor DNA from tumor cells. Can you imagine if tumor cells Okay. Of course, if you see, maybe 10 minutes left, I think. Okay. When tumor cell release the fragment of the DNA, that DNA is actually carry the genetic alterations from the tumor, right? So it's called circulating tumor DNA or ctDNA. There was a large cohort that trying to, profile the genetic alterations in ctDNA of CCA patients. You can see that there are so many alterations that can be captured in ctDNA of biliary tract cancers. And one of the most important mutations that were detected in ctDNA is actually KRAS mutation. KRAS mutations in the clinic is already the FDA approved drugs for KRAS mutations. And also the high pre-treatment ctDNA variant allele frequency was also associated with the prognosis of the patient. So this is actually suggests the clinical applications of detecting ctDNA in cancer patients and also cholangiocarcinoma. So in our pilot study, we just do the simple study first. We collect the primary tumor tissues and compare and also collect the cfDNA or ctDNA in cholangiocarcinoma at the time of the diagnosis. We did capture sequencings and we profile the level of CCA patient, whether is a difference between CCA patients and normal or patients with benign biliary diseases. So this is our pilot study. We design the deep targeted sequencing, particularly for CCA panel. We make use the tumor data. We design the capture panel to capture genetic variations that can be targeted in clinic. Of course, we need high depth of sequencing, at least 1000x of the sequencing to capture the variations in circulating tumor DNA. What we see, so we do see so many somatic mutations in ctDNA of the CCA patient, and some of those mutations are targetable. There are some drugs. So this is just to mention, this is the mutation that we can capture at the time of the diagnosis. Of course, those patients are ongoing in serial collections of the blood to see whether this mutation is actually respond to any therapy or not. Also, I hope maybe next year I try to, share the result to you guys. So these are the mutations. I would like to also emphasize that if some of you guys trying to, to work with the liquid biopsy study, you need at least 1,000x at least to capture the genetic variation, which is lower than 0.5 VAF. Anyway, it is really depends on the cancer type that you want to study. CCA is a cancer that arises along the belly tree. So tumor size is actually a lot less than hepatoma or less than small cell lung cancer, right? So for cholangiocarcinoma patient, you really need the high depth sequencing to capture the low variant with low VAF. And this VAF, why is important? Because this VAF is actually, correlate with the staging of the patients. Okay, we did also the simple study to profile whether does the increasing of the CF levels actually correspond to the stagings. And we do see the level of the cfDNA in cholangiocarcinoma patients actually, higher when compared to the patients with benign biliary cyst and the normal. Patients with metastasis, of course, there was an increasing level of cfDNA. I would like to also emphasize here again that the detections of ctDNA and cfDNA in cholangiocarcinoma patients has superior efficacy to diagnose or differentiate CCA patients from patients with benign biliary disease, which means that you can capture or differentiate CCA patients out from the patient with precancerous lesions, but level of CA19-9 and CA cannot do that at the time. So we observe the highest positive detection rates by using ctDNA mutation detecting of the level of cfDNA when compared to the positive detection rate to the CA19-9 and CEA. So lastly, for the liquid biopsy part, we do observe that our sequencing method that we developed can capture the low variance mutations in cell-free DNA, less than 0.5%, and some of the variants actually can be targetable in the clinics. And the combination of detections in cell-free DNA with CA19-9 or CEA is actually can increase the specificity to differentiate or diagnose the CCA patient with benign biliary disease. I would like to suggest here or summarize here that when you want to detect the ctDNA or cell-free DNA, right now we can say only that detection of cell-free DNA and ctDNA can be a complementary marker with the current technique. Okay, so lastly, so I would like to thank our collaborations mainly in cholangiocarcinoma research institutes and also the funding grants and our overseas collaborations, Professor Bin Tien Te, Professor Patrick Tons, and Steve G. Rosens, and our teams in National Cancer Center of Singapore, GAS, and Duke in US. And I hope that my research and my talk today will give you an interesting, of how to make use the multi-omic data to be applied in the routine or clinics. So thank you for attention.
ขอขอบพระคุณผู้ช่วยศาสตราจารย์ดร.เทคนิคการแพทย์หญิงอภิญญาจุสกุลเป็นอย่างสูงค่ะ
Any question for our participants? This gentleman, please.
Thank you for your interesting talk. I have the one question. For the ctDNA, what the purpose the cancer secreted the ctDNA? What the purpose of the cancer to secrete the ctDNA?
Okay, what is the purpose of why cancer cells secrete the ctDNA? So secretions of the cell-free DNA is actually the normal conditions that can happen in either normal cells and tumor cells. I mean, any cell type in the body is actually secretes the DNA as a waste products routinely, but those secreted cfDNA will be eliminated from your body within like 1 or 2 hours. Like you try to clean the waste products. Remember, every time that the cells like try to grow, right, or replicates, there are some like regions or points that can be mutated or mismatched. So those are also one of the, reasons. And there are many mechanisms, like main mechanisms to secrete the cfDNA from cells: apoptosis, necrosis, and direct secretions. Interestingly, tumor cells and normal cells, there is a new hypothesis. Tumor cells and normal cells might secrete the cell-free DNA from cells with different mechanisms.
I have another. Okay. If we interested to select the sample for the patient, how can we select the sample and we can extract now and can stock the serum for work further?
Thank you for bringing up this important point. If you want to work or do research in cell-free DNA, sample collections is one of the main points that you have to consider. So you are asking whether what type of sample, right? It really depends on what is your purpose of the objective. If you want to do liquid, biopsy for, let's say, you want to apply your finding into the clinics by using, drawing the blood. Of course, right? Blood is one of the minimally invasive techniques. But for example, if you want to work with the disease or the cancer that involve in brain, so you think that what do you think? Which one is better between CSF and blood? Right? Brain tumor, for example. CSF might answer your questions, but however, if you want to apply into the clinic, of course, collecting CSF is more difficult. So it's really depends on your objective of the study. And the second question is what times or when is the best time to extract? Okay, it's really depends on the container you use or the consumable. For EDTA, blood, mostly within 2 hours is cut off. But if you have money, you have more expensive and great preservative. It can be last long, like for 1 week before extractions.
Thank you very much.
Okay, thank you for the wonderful talk. Just think about I'm going to ask a naive question. So think about the liquid biopsy, right? So as you said, because it's body eliminates very fast, right? So there's poses some certain difficulties to detect those mutations in the liquid biopsy. I'm wondering whether there's a corresponding metabolite change, because there's a mutation, then certainly you would reflect in the metabolism level, right? So we know IDH mutation, there's the metabolites will, you can indicate. I'm wondering with particularly this KRAS, because the KRAS is very common as you showed, and not only in the CCA, but maybe other cancers, lung cancer, right? The KRAS come out very, very common. I'm wondering whether there's corresponding KRAS mutation metabolites similar to IDH.
Okay.
Thanks.
For KRAS, if you are asking about the KRAS metabolites, right? From my, research, from my point of view or our backgrounds, there is no such of metabolite in response to KRAS, because one thing is that KRAS actually controls, because KRAS actually upstreams of the kinase pathway. Kinase pathway controls like so many metabolisms program. So I think it's actually my opinion. There's no specific metabolite that alter in response to KRAS proteins only. Not because IDH actually the main, main proteins in the TCA, right, in the KF cycle, if I'm not wrong, sorry, I'm not a metabolic science. So 2HE is like kind of specific metabolite,
yes.
right? So
I
I agree that IDH1 should be actually explored in cholangiocarcinoma 2HE.
Okay, thank you very much.